Ensuring the therapeutic efficacy of oral contraceptives during tirzepatide therapy requires to understand a clinically significant interaction between tirzepatide and oral contraceptives. In this discussion, I focus on the mechanism of interaction between the tirzepatide brand name Mounjaro, Zepbound, with oral contraceptives, providing evidence-based strategies to manage this interaction, and counseling points for optimal patient care. For your reference, all information about this interaction has been extracted from the Lexicomp Drug Interaction Database. This interaction only applies to orally administered hormonal contraceptives. Other routes of administration like transdermal patches, intramuscular injection, vaginal rings, and subdermal implants do not participate in this interaction. Summary of drug interaction between tirzepatide and oral hormonal contraceptives. Tirzepatide may decrease serum concentrations of hormonal contraceptives. The severity of this interaction is major. This means the consequence of this interaction could be clinically significant. The risk rating category of this interaction is Category D. According to the Lexicomp Drug Interaction Database, Category D drug interactions notify clinicians to consider therapy modification and switch one of the offending drugs to a safer alternative. Further, I will explain how this recommendation is used to manage this interaction. Mechanism of interaction between tirzepatide and oral hormonal contraceptives. The interaction is not a direct chemical reaction or a metabolic conflict in the liver. Instead, it is a pharmacokinetic interaction, specifically affecting the absorption phase of the oral contraceptive. Here is a step-by-step breakdown of the mechanism. Number 1. Mechanism of tirzepatide. Tirzepatide activates a glucagon-like peptide 1, GLP-1, receptor and causes delayed gastric emptying. This means activation of GLP-1 receptor by tirzepatide slows down the rate at which food, and anything else in the stomach, moves into the small intestine. Number 2. The site of absorption for oral contraceptives. The primary site of absorption for oral contraceptives is the small intestine. The pill dissolves in the stomach, and its contents are then passed into the small intestine for absorption. When tirzepatide delays gastric emptying, it holds the dissolved oral contraceptive in the stomach for a longer period than normal. This means there is a delay in transferring the contraceptive hormones to the small intestine, which is the primary site of their absorption, and consequently leads to delayed contraceptive hormone absorption. As I mentioned before, this interaction is a pharmacokinetic-related interaction, and affecting the absorption phase of the oral contraceptive. Let's check this interaction on drug absorption curve. When a patient takes oral hormonal contraceptives, this medication dissolves in the stomach, moves to the small intestine, and starts the absorption process into the blood. The amount of oral contraceptive will increase slowly in the blood until it reaches a peak concentration, known as Cmax, to show its pharmacological effect. Later, drug elimination process will start, and the drug concentration will come down in the body. The time required for the drug concentration to reach its maximum concentration is known as Tmax. When this patient uses tirzepatide and an oral contraceptive at the same time, this drug interaction may longer the time required to achieve Tmax. The critical issue in this interaction is the timing of the absorption. Here, the concern is that the delay in reaching the maximum concentration of an oral contraceptive after initiation or dose escalation of tirzepatide can lead to a transient subtherapeutic period, where hormone levels fall below the effective threshold. This creates a theoretical window where ovulation could potentially occur, increasing the risk of unintended pregnancy. Now the question is how the interaction between tirzepatide and oral hormonal contraceptives can be managed to mitigate the harmful consequences of this interaction. Number 1. This interaction only applies to orally administered hormonal contraceptives. Therefore, advise your patient to switch from oral hormonal contraceptives to a non-oral contraceptive method for maintaining optimal contraceptive effect. 2. If your patients cannot switch to non-oral contraceptives, then advise them to add a barrier method of contraception for 4 weeks after initiation of tirzepatide and for 4 weeks after each dose escalation of tirzepatide. The reason behind the initial 4 weeks of precaution is that this interaction reduces the absorption of oral contraceptives and causes a longer time to achieve to Tmax of oral contraceptives to show its contraceptive effect. You can refer to the pharmacokinetic tips section of this video. Patient counseling. I am a clinical pharmacist, and the following are my recommendations to patients while using tirzepatide concurrently with oral hormonal contraceptives. Implement a backup method during the first 4 weeks of concurrent therapy and for 4 weeks after increasing the dose of tirzepatide. A reliable backup form of contraception, for example condoms, is strongly recommended. Consider non-oral contraceptive options, for example IUD, implants, injections, as these are not affected by gastrointestinal absorption. Prioritize consistent dosing of oral contraceptive. If continuing the oral contraceptive, take it at the same time every day to help maintain stable hormone levels. Maintain proactive communication. Inform all members of your healthcare team and promptly report any signs of potential contraceptive failure, such as delayed menstrual cycle.
Thanks for watching. If you found this helpful, hit the like button and please subscribe to get future video lessons.